Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello, welcome back. This is Adam Rosen, and you're listening to the Total Knee Tips and Pearls podcast. So today, I'm going to talk to you about an article, but there's many other articles, and there's many other book chapters on this topic. So this was just something I thought was worthwhile and something that I believe that you should read. This is a current concepts review. It's titled Impingement with Total Hip Replacement. This was in the JBJS in 2007 by Dr. Malik, along with Dr. Dorr. Dr. Dorr had written a ton of articles and papers on this topic, and I'm not really even sure I'm gonna do it justice. And for years, I've tried to create a very, simplistic algorithm, sort of along the lines of what you're used to seeing in Miller with the balancing algorithm for a total knee. But the more I delve into it, the more complicated it is because there's a lot more variables in the hip. So what I'm going to try to do is I'm going to try to make your brain hurt. I'm going to give you a lot of information. I'm going to hit you with a lot of stuff. These are things that I talk to my fellows about on a regular basis. And for some of the younger PGYs, a lot of it may be overwhelming, but I think you should hear it. And for a lot of the PGY 4s, 5s, or even fellows, a lot of this may make a lot more sense. So just understand that, hip dislocation is something that does occur, and luckily it occurs a lot less frequency now, or with a lot less frequency now than it did. I remember in residency, it was just common that you knew that when you were on call, you were going to reduce at least one hip, and a lot of those people were frequent flyers. So much has changed, and there's still a lot that can be done. So understand that impingement is a dynamic process. I am not a good believer of, not having the ability to test the leg during surgery if the leg is locked into a boot or the table and relying simply on the x-ray, because sometimes the best static x-ray isn't always a stable hip. The idea of head-neck ratio is something that you should review and check. Most people now are quite comfortable with, you're routinely putting in 36 heads. If you have a small acetabulum and you put a 32 head in, for a lot of the young residents or fellows, that's a random event they might do once, every couple of years, where, we were putting in 28 millimeter heads on a regular basis. And, docs older than me, they were commonly putting in the 22 millimeter head. So putting in 36 millimeters has made a big improvement in jump distance, especially when you get into even larger heads like 40 and above. But again, just because you have a greater jump distance doesn't necessarily mean that the hip is more stable. The other thing that we used to see a lot of too were very, very long, what we call skirted necks. We had skirts and mini skirts. So a lot of the longer heads, because the bore and the head was quite small, the head was only 28 millimeters thick, to increase the stability on the trunnion, they had these skirts or mini skirts. And that decreases your head-neck ratio, because if you had this small 28 millimeter head with a skirt, it was even less range of motion before the skirt would impinge on the cup or the polyethylene liner. So now having better metallurgy and smaller trunnions and larger heads, we now have better head-neck ratio. And that alone has really improved the stability of total hip replacements. Now, the other thing I want to just briefly talk about is lip liners. I know there are some surgeons like, I put lip liners in everybody because it's more stable. It's not more stable. It gives you less range of motion. So if you have a patient that's hypermobile and you optimize the cup position, and they have full range of motion where they almost impinge the neck on the front and almost impinge the neck on the back, this person is getting about 180 degrees of freedom. Now, if you put a lip liner because you always put a lip liner posterior or inferiorly because you believe it's more stable, you've now taken 10 degrees out. So now they only have 170 degrees of freedom, and they're more likely with extension to bang the neck on the poly, which may just cause poly debris, or could cause the poly to dissociate from the acetabulum, or worse, cause the neck to impinge on the polyethylene lip and cause an anterior subluxation and dislocation. So lip liners, in my hands, are usually utilized in patients where I have to put the cup less anteverted than I would normally for bone coverage and bone fixation. And because the cup now is flat and I want to add more anteversion, I will add the lip to change that, whether or not it's a true lip or a true face changing. And more frequently, these are in revisions. Occasionally, I'll use it more in the stiff male with a bad back or a forward flex gait. Again, they have very minimal range of motion normally. And because of the bad back and sitting posture and pelvic position, they're more likely to thrust out of a low-seated chair and could cause some additional subluxation out the back. So that adds additional stability. But in those patients who do not have full range of motion, you're not sacrificing anything because they may only have 100 degrees of freedom max. Now, people to really be aware of when we talk about stability and dislocation, hypermobile people, these are specifically usually young, thin females or Ehlers-Danlos patients. These are patients that are going to test your skills and test the construct because these are patients that are going to really push the limits of what a total hip replacement range of motion can tolerate. And the other patient, which is, and I'm not even going to go into detail, it's a whole other topic, but the idea of pelvic tilt, pelvic obliquity, sacral inclination, multiple spinal fusions from the sacrum and up, how many levels, like that is something to consider. But you have to have your armamentarium of, if you're treating a spine patient with a hip replacement, you really have to decide, am I getting standing and sitting views? Am I going to measure sacral inclination and pelvic tilt? What am I going to do differently in this patient? Watching them walk is really, really key. Are they going to have their hip first and back second, back first, hip second? And, if they have a significant pelvic obliquity, keeping in mind on what that does to the functional abduction. So you don't put a cup that looks perfect on x-ray, but then their pelvic tilt makes that cup very vertical when they're standing, or horizontal, depending on which way the pelvic tilts. So again, very, very specific details that I'm not going to cover here just for sake of time, but something to consider. Positioning, even our Dr. DeLima did a study, and they looked at, to avoid impingement, actually best abduction positions were 45 to 55 degrees, but they also found in that study that there was greater linear wear, so more than 40% wear when the cup position was greater than 45 degrees. Now, luckily, polys are getting better, so there's always a trade-off of, cup position versus wear. Now, when we talk about implants, you have a lot of control over the cup. When it comes to the stem, the idea of modular necks was a great thing because you could just drop the broach in and then you could pick and choose anteversion, retroversion, lateralized, vertical, how much length. But we now see all the problems with modular necks. So for the most part, you don't have as much control on the femoral side. Now, if you're putting in a cemented stem, you have a lot of control. You can pick and choose the version of the cemented stem when you put it in, but you got to get it right. If you're using a modular stem, you have the ability to put it wherever you want. If you're using an ML taper, there is some wiggle room of, where you can put it as far as version. But if you're using a true broach body, a lot of times the bony anatomy is going to dictate the version, and it may match the patient's version, but it may be off. And then you have to figure out, how do I accommodate that with the cup?
We'll be back after a quick break.
Once a person is triggered, there are biological changes that happen in the brain that zap your energy, motivation, and sense of pleasure. Now, that in itself is not depression until people get into the depressive loop. It's very easy for people to stop doing things.
Yeah.
And you get into what we call an avoidance pattern of behavior. You stop doing things that give you a sense of mastery and a sense of pleasure, right? And you withdraw because the brain's basically like, hey, if you're not going to do this stuff, then I'm not going to give you the chemistry you need to want to do it.
Yeah.
So the less you do, the less you feel like doing. The less you feel like doing, the less you do. Now you're in the loop.
So all of that is stuff that you have to kind of keep in mind. And then it comes down to the implants that you use. So it is important to understand the implants and know, okay, for this company and this cup, at what size cup do I get 36 millimeter inner diameter aligners? And if I get it, do I get just a 36 neutral, or do I get 36 with lipped? And do I get 36 eccentric? So that becomes something to consider if you're dealing with a small patient that's hypermobile. You want to make sure that you have a company that affords you the ability to put a 36 in at a small cup size. The next thing you have to worry about is, okay, on my stem, how many stem options do I have? And if I put the stem in, what is the neck shaft angle? And how does that fit with the patient's anatomy? Do I have a lateralized neck shaft angle? And does it push it straight lateral, or does it push it lateral and does it also add length? Do I have a coxa neck? So in certain systems, like in Stryker, you have more of a vertical neck, a 132 and a 127. In other systems like Zimmer, DePuy, you might have your regular standard neck shaft angle, and then they offer a lateralized. So it just pushes your stem out. A lot of the companies also offer these coxa necks, which drop it down even lower, like 126, but also you lose length. So you have to understand what options you have and say, okay, well, in this company's implant, I have the ability to push it lateral, or I have 2 neck options, and take that into account when you do your templating, because depending on your neck shaft angle and the length of the neck and your templating, that's going to help determine where your neck cut is to best balance your offset and your length. And we're going to get into, this is a lot of information. We're going to get into the idea of what I do and the algorithm of balancing. But the other thing you have to think about, and this is something that I think is complicated for younger residents, but the idea of where you put the cup. So reaming, I know for a lot of people, is something that you don't really get a chance to do until later on in your training. But it is very complicated because we're reaming this in space 3-dimensionally. And you're taught in the beginning, think abduction and anteversion. Okay, that's the cup position. But you have to look at each cup individually and decide, okay, how thick is the medial wall and where do I want to medialize it to? Because some people are taught to medialize straight down. But if you medialize straight down and you get to the floor and then you change your reamer position and put it in your abducted position, a lot of times you have that superior sort of bubble. So on the x-ray, it almost looks like you're not down, but it's just that the way that the dome was when you reamed straight down, you actually have a little cavity there. So what I always teach is kind of medializing a very little if there's not a need to medialize a lot. And if there's sclerotic bone and there's a huge curtain osteophyte and we have to medialize a lot, we may medialize a little aggressively in the beginning and then start putting our cup or our reamer into the position of abduction of the cup that we want. Now, if you have a retroverted cup, sometimes on purpose, you need to take a little bit more bone with the reamer off of the front of the cup to get the cup to seat. Always think about where the anatomic rim is if you're not dealing with a dysplastic cup, and think about, okay, how do I get the face of the reamer inside and sort of anatomically where I want to put it for the cup? Because sometimes you have to take more bone off the front half or more bone off the back half. And that occurs with your first couple reamers, so you can dictate your version. Because if you go straight down and then you want to antivert, then you wind up taking bone off the front half, but maybe you needed to take it off, the back half. So those are weird little things and subtle differences depending on, are you retroverted to begin with? Is it overly antiverted? How much medial wall do you have and how much do you have to medialize? And then the other important thing is, when do you start to abduct? Because if you have a thick medial wall and you put your hand in 45 degrees and ream in and up, you're going to raise your hip center. And if you raise your hip center, that changes your leg lengths. So you have to determine, okay, when do I have to start aiming up and how much floor do I have left to go, because I have to medialize and aim up to put the cup in the appropriate position. So this is where templating comes in handy. And the other thing is front and back. This is most commonly seen. I see this more in a posterior approach, muscular male, and the femur's in the way, and the reamer gets pushed out the back. Either seesaw, ability where you kind of ream inside and outside the posterior wall. But what that does is it moves the hip center posteriorly. So on the x-ray, it looks like your hip center might be up and down in the right place, but the hip center is posterior. So now the troch will impinge on the ilium early and cause dislocation and instability. So really knowing where that cup is in space. But again, that's a lot of training and a lot of technique and a lot of hands-on, a lot of visualization. But understand that where the cup goes isn't just abduction and anteversion. It's medialization, it's anterior, posterior, and superior. And all of those factors come into play. And now we're going to get into the gist of the idea of what do you do. So this is where I can't come up with every option, but I want you to think about these things. So it's great if you put the cup in, you put the liner in, you put the broach in, you put the head on, and it's leg lengths are equal, soft tissue tension's great, and it's balanced well. That's great. Then it's a no-brainer. But that doesn't always happen. So when I put my trials in, and again, this is based on preoperative templating and intraoperative findings, there's a whole bunch of things that I do. So the first thing that I do when the trials go on is I check my leg lengths. And again, I'm a posterior guy. I don't do anterior. But in the lateral position, I'm checking the leg length. And before the patient is positioned, I'm checking the leg length when they're lying supine before we position them. And I want to know, what did the patient feel? Did they feel short or equal or long? What do they measure clinically? And what did the x-ray measure? All that information goes into my head. They get positioned laterally. Is it the same? Were they a little short supine and a little short laterally? That means to me that the pelvis is probably straight up and down. Whereas if they were a little short supine and they're really short, then the pelvis is tilted. And what that means is that when I put my cup in, it may actually look a little off the 45 degrees, because if I put it 45 and the pelvis is tilted up, it's going to be closer to 35 when they stand up. So that cup may look a little bit more vertical. Whereas if they were a little short supine and now they feel long, then the pelvis is tilted the other direction. So if I put my cup in at 45 and then they stand up, it's going to look more vertical. So you have to kind of keep those little things in mind. But I always, check my landmarks and check my length. Okay, I like my length. I put my finger in and I feel the intercapsular tension. Like, what does the capsule tension feel like? And what did it feel like beforehand? And was this what I'm aiming for? And then what they talk about in the article, and Dr. Dorr has talked about this before, is checking the distance between the lesser troch to the ischium. And, they talk about getting at least a finger between to prevent impingement, which lets you know that you probably restored the offset. But I always like to check that before I start. Where was this patient clinically, as well as looking at it radiographically? And that helps me know, okay, my leg lengths are appropriate, my offset feels appropriate, my soft tissue balancing feels appropriate. The next thing we do, which he talks about in the article, is checking the combined Ranawat sign. So what this is the hip is pretty much in neutral or slight hip flexion. And then what you do is you'll internally rotate the foot and the hip up until the face of the trial head is parallel with the face of the polyethylene liner. And what you're aiming for is about 45 degrees in females and about 20 to 30 degrees in males. And this is something that I've used my entire career, and I find it extremely, extremely helpful, because if they're mated, then the combined version, that functional range of motion, for the most part, is usually stable. And if they're not, it gives you an idea of, before you even check an x-ray or look or test the stability, you know what? This cup is vertical. This cup is horizontal. This cup is retroverted. This cup is anteverted. But instead of thinking it in that up-down, front-back plane, think of it like a clock face. So when I look at that cup and I look at the coplanar position of the head to the acetabular liner, I'm trying to think, do I need to antivert it and abduct it? Do I want to move the cup maybe on the plane of, say, from 5 o'clock to 11 o'clock versus 9 o'clock to 3 o'clock? And that gives me the idea of, if I'm going to move the cup, what position am I going to move my hands? I see a lot of people just try to move up and down, abduction, front and back, anteversion, but think of it like a three-dimensional object and try to pivot it around the center of the cup and move it into that optimal position if need be. So the next thing that I do every single time is I will bring the leg into extension. Check my rectus. How tight was it beforehand? How tight is it now? Are you too tight? Did it feel too long, or does it feel too long here? And then full extension of the leg and external rotation. This is looking for this posterior superior impingement point. This is one of the most common places. Yamaguchi actually described this. He talks about this point, this posterior superior point. I see this most commonly in hypermobile females, but the neck will impinge. So if you're dealing with patients, say you're standing on the back of the table, patient's left hip, you're talking about the neck impinging around 1:30, 2 o'clock. And that, again, can lead to subluxation or anterior instability. So we've checked it in extension, external rotation. Next position is sleep. So drop the top knee in front of the bottom knee, internally rotate the foot. Shouldn't see any subluxation. Then I pick the knee up so the leg is at neutral, flex it all the way up to, say, 100 degrees. Usually you start to hit the retractor on the front of the pelvis at that point. Stable. Okay, bring the knee to 90, drop the knee in, adduct, and then see is there any subluxation or dislocation. And if the leg lengths were equal, the soft tissue balancing is equal, the combined Ranawat sign is appropriate, and all those testing points, that functional range of motion that you've now tested are stable, the odds are this is going to be stable. But then I get an intraoperative x-ray, and I'm looking at this intraoperative x-ray. You heard me talk about this before. The first thing we're going to do on the intraoperative x-ray is decide, is it a good x-ray? Is it rotated? Is it an inlet or outlet view? Because then you have to take some of what you see with a grain of salt. But then you're looking at whatever order you want to do it, but the same way every single time. Is it a good x-ray? Number one. Okay, let's look at the stem. Is it well fixed? What's my neck cut like? Is it in varus? Is it in valgus? What is my offset? How is it compared to where I started? What is it like compared to the other leg? And then looking at the cup. Am I medialized enough? Is it abducted enough? Is it anteverted enough? So all of those things come into play. And then depending on the stability and depending on the x-ray findings, you may make changes. Okay, so let's say now that you put the construct in and it's not stable. Let's say you need offset. So you want to add offset, but your length is okay. So in certain cups or certain systems, if you don't have just a pure lateral offset, if you have a 0 ball, let's say you want to add the next larger ball size, maybe 2.5 or 3 millimeters or 3.5 millimeter ball length. Well, when you do that, you're adding length and offset. So if you love your length, but you just need offset, then what you may need to do is you may need to countersink the broach to lose length, but you're going to gain some of that back when you go up the ball size, which is now also going to give you more offset. And by giving you more offset, now you're going to have that better stability because you were impinging, okay? Now we have to go back a second and say, okay, well, where was it impinging? And we have to think about anatomic versus implant. And this is something that Dr. Dorr has also talked about previously in a lot of his papers. So when we're talking about instability, and I probably should have talked about this first, but if you're unstable, you have to ask yourself, is it unstable because it's implant impingement? Is my neck hitting my cup? Or is my troch hitting my pelvis? And they're two different things, and there are very different ways of treating it. So if we talk about, Yamaguchi's decision of, or, kind of finding of hitting the cup, and Dr. DeLima's finding of, cup position having the most range of motion at 45 to 50, I do find that more of my younger, active, hypermobile females, overall, those cups are a little bit greater than 45, and my stiffer males, it's more 45 to 40, because they will impinge either posterior superiorly or anterior superiorly. So if you find that your neck is impinging on the cup and you can't move the stem, then you have to move the cup. And the question is, do I have to make the cup more vertical, or is it hitting on one side? Do I have to retrovert the cup a little bit or antevert the cup? So that becomes an implant issue. The other issue is, maybe, your cup's too proud. Maybe you didn't medialize enough, and maybe you're hitting, maybe you have to sink this and further medialize your cup. But more commonly, I would say than not, is hypermobile people, neck's going to hit superiorly posterior or superiorly anteriorly. And then you have to decide, do I have to make the cup more vertical if it's hitting equally in the front and the back, or is it hitting on one side versus the other? And do I have wiggle room to antevert or retrovert the cup so there's no implant impingement? So that becomes the implant aspect. Next thing, which is more common, though, is soft tissue or anatomic impingement or bony impingement. So in this case, we talked about probably the troch is hitting the pelvis, so we needed more offset. The other option might be a lateralized stem. So if you have a stem with a lateralized neck, you have to know, does this company add 6 millimeters? Does it add 8 millimeters? And if so, is that going to be too much? Now am I too tight, and am I going to get troch in bursitis because I've pushed myself too far lateral? Okay, well, how do you fix that? Let's say you really, really need more offset, but the 6 or 8 millimeters that you're given with the stem is too much. Well, how do you get rid of that? How do you fix that? Well, one option would be take your cup out and further medialize your cup, say 2 millimeters if you have 8 millimeters of lateral offset on the stem, and now you have 6 millimeters of total offset. So again, if you templated, you would have the ability to kind of control that before you go in, but you can do these intraoperatively to make those little tests. Now, what about if you are stable as far as the overall stability of the hip and offset, but you're short? Now, one option is, again, you start adding head lengths, but depending on your neck shaft angle, you're going to add both length and offset. The other option, sometimes, maybe you cut your neck too short. So one option is you can go up on your stem size, and you pot the neck stem size a little proud. And it may look proud, but maybe that's where the neck cut should have been. And again, you may have figured this out if you did your templating, but that's going to add pure length. And it's going to add no extra offset if, again, you have to know your stems, if it's not a stem where the neck length jumps as you grow with your broach body. So in some companies, the stem or the neck length is all the same. So you have to know that. In some, you may jump every few broach sizes, the neck length gets anthropometrically longer. So knowing your stem and going, if I go up, I'm also going to add lengthen my neck by, say, 5 millimeters, but I can go down 5 millimeters in my ball. Okay, that'll be equal, but I'll just pot it proud and I can add just length. So that becomes another option. The other thing that you have to look at, too, is when you're talking about anatomic impingement is the trochanter. So this is something I think a lot of people miss very commonly, and I see this either when you make your neck cut, before you translate your femur, look along the anterior border of the femoral neck. And a lot of times there's osteophyte. There's a curved curette that I will utilize, and it will scrape that off and then use a rongeur to get it out of there, because without those osteophytes, there's less tenting of the anterior capsule, and it allows me to translate the femur more anteriorly so I can expose the acetabulum. But it will also add to impingement. And if it's adding to impingement, it can impinge in the front and cause your hip to sublux or dislocate out the back. This can also happen on the acetabular side. So my plan always is once the cup goes in and the trial liner goes in, is I stick a finger up there and feel, and if there's osteophyte, which there typically is, I'm using a curved osteotome to take that off. Otherwise, your osteophyte, and then this again is anatomic impingement, is going to cause impingement on the neck or on the femur and cause posterior dislocation or subluxation. But the other spot to really keep an eye out, and I usually use a little Homan, and I'll put it underneath the abductors, is just where the greater trochanter sort of meets where your osteotomy is, the piriformis fossa, but anteriorly. There's a lot of times osteophyte hiding there. And that's a very common spot where it will impinge either on soft tissue or on the bony pelvis and cause this posterior subluxation or instability. And I see a lot of people will chase it just by adding neck length. They add offset, and by adding offset, now all of a sudden you're increasing the risk of trochanteric bursitis, where if you just took off this osteophyte and went digging, I usually dig with a bovie until I find it, take a curette or a small rongeur and nibble that stuff off. And usually it's just about the tip of my pinky finger, but it's an osteophyte and it does impinge, so you want to take those off. Next things to consider, let's say for certain systems, you don't want to jump to the next ball length because now you've added too much length and offset, but you need something in between. Some do offer a lateralized liner, so you're pushing your hip center out, and depending on how far that pushes it out, it may push it out sort of halfway between what the ball is that you have and the next ball size. So that kind of gives you an intermediate zone. But again, knowing your system and knowing what your lateralized liners are, that's really important. So think about implant impingement. And if you're hitting neck on cup, why? And can I make it more vertical? Can I make it more anteverted? Can I make it more retroverted? If you're having anatomic impingement, you have to ask, okay, well, why? And if it is acetabular, take off the osteophytes. If it's femoral, take off the osteophytes. If it's bone on pelvis, then you have to decide, okay, do I need more offset? So I can add offset by a lateralized liner. I can add offset end length by adding a ball size. If I don't need the length, but I do want to add length, or I do want to add offset, and I would do it with a ball size, I can sink my broach, which gets rid of the added length of the increased ball size and gives me just pure lateralization. If I need a lot of lateralization, but no added length, I can use a lateralized neck on the stem, which depending on the system usually is between 6 and 8 millimeters. If I need that lateralization, but the 6 or 8 millimeters is way too much, but I still need it for stability, and if I do it, I'm going to have troch bursitis, I can take the cup out, medialize the cup a couple millimeters. That will give me either 4 or 6 millimeters of lateral offset and still not give me the added risk of troch bursitis. If I need more offset, and in some systems, it's a little long, but I need offset. You got coxavera next. So just knowing, does it go coxavera, and do I lose length with that? Or Do I just, get more offset, and is the neck more varus? So again, knowing the system is really, really key. Maybe you have plenty of offset, but you're short, and that's why the troch is impinging, and you need pure length. Again, so one option would be you could add a ball size, but you have to medialize the cup straight medial, because if you medialize up at 45 degrees, you really haven't changed much, because you moved your hip center rotation in on the acetabular side and up on the femoral side, but you could move it straight medial would be one option. The other option is going up a stem size if that jump in the broach does not add neck length. And by broaching up and leaving that neck stem proud and using the same ball length, that is going to give you pure length and no additional offset. And at the end of all of this, the most important thing, through the posterior approach is having a meticulous approach and a meticulous closure. That capsule should be closed anatomically. I like to see just a little sliver of metal of the neck just above where it actually enters the femur and not anything else. And the piriformis needs to be repaired back anatomically, which means that you needed to take it off anatomically and be able to expose all the way down to the piriformis fossa and take it off basically blindly, but by feel, so you don't leave a centimeter stump and now have this piriformis that you either can't repair or you have to advance all the way up on the abductors. And by doing all of these things, I believe that your chance of dislocation should go down significantly. So again, meticulous approach, and the importance even before is templating, and feeling the leg clinically before you start and having an idea of what the length and stability is like. And then once the trials go in, of going through this algorithm of what is the length, what is the soft tissue tension inside, what is the finger breadth distance between the lesser and the ischium, and then going through the combined Ranawat sign, making sure that you have sort of this coplanar position of the head to the face of the acetabulum, making sure an extension that you're balanced, your rectus isn't too tight, which could indicate that you're long. Sometimes it's tight just because they were really short and you had to make that up. Extension, external rotation, that you're not impinging the neck on the posterior superior aspect of the acetabulum. If so, you may need to correct that if they're really short and loose by adding a ball length, which would tighten it up, or by making the cup a little bit more vertical or a little bit more retroverted. And then position of sleep, making sure it's stable. If I have neck impingement on the acetabulum, most likely you're retroverted. You may need to antivert that cup. If your neck is impinging anatomically on an osteophyte, you got to take the osteophyte off the front of the acetabulum. If there's no osteophyte and the cup's appropriately antiverted, you may have anterior osteophyte on the greater trochanter or the femoral neck. That could cause posterior subluxation, so you got to take that off. If it's impinging there due to lack of offset, you may need more offset, which again you can do with a lateralized liner. With a longer ball length, if the hip is long, you may need to countersink the broach to make up for just pure lateralization and no added length. You may need a lateralized neck on your stem. When you bring it up into full flexion and internal rotation, again, you have to decide, is the troch that's impinging on the pelvis, is there osteophyte that I can remove? Is there not enough is there not enough offset? Do I need to add offset? Is it possible that my cup has been pushed posteriorly and I am actually impinging on the ilium earlier because I reamed inappropriately and the cup was put further back? That's a hard thing to fix at that point. You may need to chase that with more offset unless you have enough bony stock where you could re-ream and create a more normal, natural hip center, which would be a little bit anterior to where your acetabular component is currently. So again, a lot of information. Really, really think about this. Really, really read through this. I'll put in the show notes the link to this article, and then what you should do is go back through their references and pick out some more of those articles and just kind of read to get a good idea, but create an algorithm of looking at the intraoperative x-ray and looking at each patient on the table with a trial so you can go through every single time. And if you test this with every single construct, then you're going to get a great feel of what is stable, what is not stable, and what are these subtle nuances of when does it sublux and when does it dislocate and what's impinging. Is it anatomic? You got to get your finger in there. You got to feel like, is it neck on cup? Is it, bone on pelvis? Is it osteophyte? Because only then can you differentiate anatomic from implant and what's causing the problem, so you can then correct it, which will lead to developing a more stable hip and patients that are happier because they have lower complication rates. So a lot of information, and keep listening. I hope you're enjoying what you're hearing. A little tiny kind of deviation from most of the total knee stuff that we're talking about, but the occasional hip stuff thrown in there to boot. If you haven't subscribed already, please subscribe. And if you haven't shared this information with your co-residents, let them know so they can listen in too. Stay safe until next time. You've been listening to the Total Knee Tips and Pearls podcast. I'm Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.